Should I hit the button here or
No, I don't.
Okay. Well, it's such a great honor, and I'm so excited. And see, this is my second time to wear the tie. The first time is with my daughter's, only daughter's wedding, so so this is so important to me. I'm from the University of Wisconsin, Madison, and next slide. So my research is based on the three fields: is etiology and assessment, as well as the treatment for the voice disorders. And my lab is question-based, and the research technology I use is kind of all over the place. It's not very deep, but I think can answer my questions. So one of the projects I like to present is a measurement of intraocular pressure and a collision force. And I learned these things from my mentor, a PhD mentor, Ingo Titze's lab. And in 1996, this is one of my first research did when I moved to this country. And it's excised larynx setup. And basically, we cut the larynx and we mount the larynx on a pipe and we give the supply of the air. So we can control the phonation mechanically. So, and this is one of the typical picture there, but you can use the pin to control the aryngenoid cartilage and to simulate the different type of phonation. We can even suture a vocal nodule there. So this is one of the type of research I start with from Ingo's lab. And then the hemilarynx setup is one of the extension of the excised larynx. And basically, we cut one side vocal cord and replace by a vertical plexiglass. And the advantage of that is we can see from vocal cord from side view, and that means we can see the contact area, and we can see the vertical movement of that. And if we put a sensor, pressure sensor on plexiglass, then we can see measure the pressure curve. So, so this is going to help us to understand what is the pressure in the glottis and changes. And this is one of the picture used strobe technology, so we can see simultaneously for the pressure curve as well as the image. So we basically see the two peaks. One peak is collision peak, when both vocal cords hit each other. The second peak is aerodynamic peak that push vocal cord apart, basically drive vocal cord vibrate. And this is another thing we try to let us to see from the front view, coronal view, and how the vocal cord vibrate. We can see two peaks and a different stage in how the vocal cord we call it like a Bernoulli effect, but that's not a negative pressure in that case. And to bring the vocal cord together and open the vocal cord. So this is a fundamental study for that. And then we see two peaks there. Again, these two peaks can be separately measured and modeled. It can be used to understand vocal cord vibration. Okay, then the second area, the serious project I like to present is phonation range and biomechanics. basically, it's also started with my aerodynamic, the exercise larynx project, and we got a larynx sometimes from pigs or some other lab from cadaver, the dogs or cadaver. So sometimes we can make larynx vibrate, sometimes we cannot. If we make a small cut on the larynx, and this screws up everything. And we saw the nodules, and also when you have a nodule, we cannot vibrate. So then we are thinking the larynx as an instrument, just like a violin maker. You know, you have a violin, looks like the same, but sometimes have a big range, sometimes doesn't have a range. So we start from there, try to do more study. So, of course, a range cannot serve a measurement. So, you know, I can lift 50 pounds, I can lift 200 pounds, that's my range. But that's not the measure to represent my power. Same as the larynx. So then we start to find some kind of critical points for the larynx, which is phonation threshold pressure. That's minimal pressure can drive vocal fold vibration. And also the maximum pressure when we apply the sublaudical pressure, sometimes your vibration to a certain kind of level, you know, the voice is broken. It's like in the football yard. You scream and then sometimes you don't get regular vibration. So this is another point. It's phonation instability pressure. All these things are derived from Ingo's lab and stars. So this is noise, and we had for irregular vibration, and let me see, I couldn't play this regular vibration. All right, that is the image for irregular vibration. And this is a 36 centimeter water. See, chaotic, not regular. And then the upper one is more regular vibration. Start with a 6 centimeter water. So these are critical points there. We can evaluate the larynx. It's the nature of the larynx. So it's not like a range. The range by itself is certain, like a vibration point doesn't really measure the ability of the larynx. So what is range are determined, this critical point, is determined by mechanics. So as I said, if you damage vocal fold a little bit, the structure damage, it's different. So there is a study, the model we can use to study the phonation threshold pressure, instability pressure, and we can even get a bifurcation diagram there. I mean, many of you would be more expert than I do. So we did use this tool. So we tried to study the tension imbalance, mass imbalance. And this is one of these models. We try to see the bifurcation diagram from my postdoc. And we started at a certain kind of level, such as 6 centimeter water. And then we move the increased pressure, then vocal fold to get irregular vibration. So this is something we like to do the measurements. We're going to talk about in the future. And for studying phonation range, and we also, in some larynx, when destroyed to a certain kind of level, you never get a good vibration. So in that kind of case, we see your PTP and the phonation instability pressure are merged. So these things, from model, you can make it getting smaller range, smaller, it can be merged. So this is why some larynx never phonate. And Ingo did a calculation for this phonation threshold pressure based on biomechanics of vocal fold. So this is very important work. And also, Dr. Herzl did a tension imbalance, physiological model for imbalance. This is very original work, and we all learn from there. And my model is based on a little bit modified from his model. So this is, we try to use model study polyps, nodule. We studied edema. And we found, and also we studied incomplete glottal closure. And we found the PTP and the PTF, phonation suppression of flow, as well as the instability pressure, all changes, and as well as vocal fold efficiency. So this is matched with our clinical finding, and in the phonetogram we see the range are getting smaller when you get a nodule. So this is have some clinical support for our finding. And we also can measure the model the local mass. We model vocal polyps, for example, and we give the different size of vocal polyps. We see when the sides are small from this one, and the vibration is still good. That means a little bit imbalance, and that should be okay. But when we reach certain kind of level, the size of a certain kind of level, your vibration getting pretty easy to get rough, or maybe you never get regular vibration. So this is from the model we can see that. And also we can use a similar model. We can understand how the aging voice coming from. We know the wrinkle is more like a mass, so you can easily to model this, and you see the aging vibration is not that regular, a little bit cracking there, and so this is one of the way to understand the aging voice. Of course, you have some neurological control issue there. So this is the aging and wrinkles, and we all understand this. And there is a study from Hirano, Shigeru Hirano, and they studied aging rats, and we saw wrinkles, and we saw reduce of the collagen and that kind of thing. So it does match with his study. And water is so important in phonation. And first I'd like to represent a rehydration model. So we just use the dry air to dry out the vocal fold superficially, from the surface. And so we also put the larynx back in the water, and that's to rehydrate it. So this study is stimulates the conversation with Kitty Vanolini. She's a hydration lady. So so this is our results. We see a hydrated vocal cord and getting the lower phonation threshold pressure, and we rehydrate it, and we get recovered. So the sound's getting better. So this we know now. We know from from experimental point of view, exercise larynx point of view, it does restore phonation. So this is flow results the same. So it's increased this better. So we know dehydration and hydration affects vocal fold so much. In the clinic, we saw edema affects vocal fold vibration. It's increased the mass. The edema could decrease the stiffness. And from dehydration, we change the shearing force, which is we all have model and we have data to present. And then we like to study more about how the edema and the fluid accumulation and the water basically in the vocal folder, how they move around. So with that, so in order to study that, we need a biphasic model. So it's very important to, when we have a tool reach certain kind of limit, say like a sprinkler mass model with rich limit, we need a better tool to study something. So it's important to use that model. And this is the reason I mentioned this model is that this is my first research when I'm a second-year resident in China, and in 1985. Mucosal accumulation and looks like a pseudocystic. We saw this clinically all the time, and one of my mentors thinking, and I read about a paper from Gary in 1973. It's very early. And people already noticed this could be caused by the accumulation of the mucus. So this is my first study. These are two of my mentor here, and Dr. Wang is my neighbor, basically. He's the person how to introduce me to this voice area. He's training friends before from Potman's department. And another Dr. Wang is trained with Uwu Fish, and they both are lead me to this area. So I dropped the red ink to both sides of vocal folder, and then make the strip vibrate. I saw the water accumulates and go to the middle point. This is the really 1985 picture. So we saw this could support their points there. And when I came to this country, when I had my own lab, I tried to study this area. I put a little tube, soft tube there. I saw similar accumulation. And that pressure, that accumulation, it seems like it's going to be pretty high pressure that caused by vibration. It broke capillary. So this is one of the study published in Laryngoscope, and we see such accumulation could cause the vascular damage. It would match with what you saw clinically, and this is we saw this. I think this is real, and in fact, the pressure could be very high, and can be like a 50 centimeter of water when we're screaming loudly from the model. So it is real something. And we like to study more, and based on Dr. Ski Gray's study and vocal folder microstructure of the vocal folder, and we try to do better modeling for the interstitial fluid measurements. And so then we use one of the model, is called the biphasic model. So the biphasic model, again, it's a pretty popular in the biological science, but we are probably first people to use that. And so basically, the vocal folder or any tissue is considered as a pores, a little solid part, as well as have the liquid part. So the liquid part can flow in that model. So this is a good model to study the water in vocal folder vibration. So again, the capillary net is kind of important. And in pathology, we saw the vascular lesion, and we believe this model can bring us something. So, and also this model have a very solid mathematical background in there, which I don't understand, but my postdoc helped me with that. And yeah, so this is, we did a filter redistribution of the vibrating vocal cord. We see if vocal cord is stay there, we don't have this force. But vocal cord will vibrate. And then we have this pushing force to the middle part of the vocal cord. So this can be mathematically modeled. And this is sort of kind of matched with Steve Gray's early description. And the fluid density and due to vibration could be changed. And so this is important to understand in terms of how the vocal nodule are formed. And we did a further study. It's with my student, Matt Hoffman, currently he's a star at the University of Wisconsin, at the Iowa. And he did this model with, he saw, see this color is vocal cord, vibrating vocal cord. There's a lot of holes in there. And these holes inside have pressure. The red means high pressure, the green means lower pressure. And when the vocal cord vibrates and then the edge of the vocal cord get high pressure, that pressure is going to break the capillary and cause a series of damage and induce the inflammation reaction, and which is you certainly know better than I do. So this is a simulation. So this is how the pushing the fruit to the middle points there. I think that this is based on our model. And so if this would have a more accumulation, then you could cause polyps. So I think that's one of the reasons how nodular polyps formed. And this is one of the questions I brought to Ingo's lab when I started my PhD. So this is showed how to destroy the capillary. When we have this accumulation, and then we make the capillary enlarge, and the inflammation factor release, and the fiber damaged, and epithelial damage. So this is the way, at least I think is important. So, so this is a capillary lesion. When you have a force, you're pushing the pressure, enlarge it. So, get inflammation. And then this is similar. This will happen on the vocal nodule, so, and the vocal polyps. I think that's a way, a part of least vascular lesion, not probably cover everything. So then next I like to see when we have a mechanical, have a nodule, what happened? What about stress? People talk about stress. So this is going to be next study, talk about, we try to see how the stress would affect the, by the nodule. So we use a different type of model, and this is final element model. So we want to study how the nodule and the polyps generates. Again, same topic. And so we just model it based on the structure of vocal cord. We model the 2 layers. And again, the FDA is a very common technology in the biomedical engineering. So we just borrow. And as Ingo said, at least I'm a translator. I'm not originally, invent this method. So I totally think that's the way we're doing. And this is 2 layers, and we measure the body and cover based on pathology. So, and then more, we put a nodule there, we kind of mass there. We could put different size of the mass there. And that's one of the easy way to do the model, just to do whatever you want to simulate it. And we make the model vibrate, and we observe the stress. And we found in the base area of the mass have a very, very high stress when the vocal cord vibrates. So, and this is, the bigger the nodule is, the higher the frequency, the stress is higher. So this work is, I did with Dr. Dave Hanson. He is my mentor. He gave me my first job, and he taught me how to write a grant. And I worked for him for 10 years, and then that is the study I did with him. And so the mechanical stress at the base of the nodule is pretty big and proportional to the nodule size of the polyps. And also, when the frequency high, for example, when a female voice, when the frequency go to like a 600 hertz, and then it's very, very hurting if your intensity not reduced. So that is one of the way we think this could cause micro inflammation. This could cause damage of vocal cord. And also, when you see one area get inflammation, so if you don't stop the inflammation, and then this high stress would cause more inflammation and make the nodule and the polyps bigger and bigger. Well, so next things I like to move to some of the study we did with chaos for vocal cord vibration, and we try to solve some of these problems, how to improve the acoustic analysis. So we know there's if we use a if we study the acoustic, do the acoustic analysis, there's one problem is we will have errors if the vocal cord vibration getting very irregular. And for example, some my colleagues want to repair larynx from cancer. So the vibration even after repair is very rough. In that kind of voice, it's hard to use the Jiang Schimmer to analyze. And this is naturally to understandable, and because Jiang Schimmer, you need to mark that. It's a cycle by cycle variation. You need to mark the cycles. But however, when the vocal cord getting very irregular, when the nonlinear property get dominated, and it's very irregular, then you can't really find any cycles. How you can find cycle from that kind of signal? So then we believe the nonlinear dynamic method and many parameters from there. Again, we transferred this from the mathematicians to move here, and we try to use their parameter to do the measurements there. And Dr. Ron Bacon is the first person, as I know, probably did the measurements for nonlinear parameters. He did D2, and Dr. Giovanni also did some of these measurements. So we follow that because so many parameters, some are good, some are in certain kind of range are good. So we did a D2 with a few of these. And we found it's an advantage. We found an advantage of that kind of parameters. And for example, this is a cancer patients. And we saw the pre and post surgery. In the pre-surgery, very messy. We can't get the accurate Jiang Schimmer. And also, Schimmer failed to show a significant post and pre and post results. And because, why? Too many errors. In general, it's a bad voice, and too many errors. But however, we use the nonlinear parameter. We saw it's have a more powerful distinguished power for that. And then we try to compare different methods with some noise. From the type 1 noise, which is irregular noise, pretty irregular, we found that there's a lot of consistency. We use different software, it's all similar, and including chaos parameters. But from the bottom signals, when the signal go to like a type 3 signal, it's the only nonlinear parameter have a small range. That means they're more accurate. And then for the other parameters, it's just all over the place. But I'm talking about very irregular type 3 type of voice. I don't want to say the chaos method is good for everything. So we saw but however, in the real voice measurement, we found that there's a 25% of the signal you have like a weird high frequency signals in there. You can't do the analysis somehow. Use the regular nonlinear method because these signals have infinity in D2. That means of course this is with infinity degree of freedom. It never happened in the real vocal fold vibration. So, and we are right. We just only consider the finity of D2. But however, in real life, in real signal, there is some high frequency components, there is some noise there, and it really reached the infinity of D2. So we want to study a real signal, and maybe we should consider the type of 4 voice. We call it type of 4 voice. That means have a very high frequency components. It's with the infinity of the degree of freedom, and in real. But however, again, these signals never come from vocal fold vibration. It's come from a turbulence, and so that is we try to modify voice production method. And you see the first is type 1, type 2, type 3. It's regular, and then we have turbulence. We have frigatives, and then these are cause these kind of in real signal you record it. So we should consider that. So this is a very little contribution we did, we feel, to improve the software. And another thing we did is aerodynamic assessment in our lab, and we feel they are important. And also aerodynamic measurements sometimes are hard to do, especially in children. So we feel we want to make it easy to do for in children as a translator in this area. So so we're doing the measurements of again, this is from the model. We think the voice cannot be measured only from acoustic, because the simple reason is the acoustic can be voluntarily controlled. I can give you a voice like this. I can also give a voice like and then they're different. So, and then it's very important to find some way to evaluate a larynx by itself. It's not just consider a control reason. And then we feel that aerodynamic is a good way to do, from, as I said it before, from a larynx we can, based on biomechanics, we can know its range. So these range are determined by phonation critical conditions, which is one of our PTP, phonation instability pressure. Some others we developed 6, 7 of these. I don't have time to talk here. And then, so these critical parameters, phonation structural pressure, phonation structural flow, and it should be measured. And then we find some way to measure. Our lab is spending some of this time. And we know the subglottic pressure measurements, and is one of these aerodynamic measurement. And also formation threshold pressure. There's many devices are built for that. And one of the devices is made from the K matrix. And so PAS, and so many of you use it. And you just have to say pop, pop, pop. But when you really use that, it could be various. I could say pop, pop, or pop, 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 pop. So it's just not very consistent. We try to improve of the consistency of that in the lab. So this is our device, and we try to use the mechanical interruption because machine is more reliable than your lip because your lip is controlled by you, and we are not reliable. So, and then somehow we feel the power is better. So here is one of the device, and instead of you say pop, 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 it's giving you interruption. So, so we found that's more accurate, basically. We have a bunch of studies show that the variability of this study is more accurate. I mean, more smaller, and we believe it's more accurate. And in another way, because you have the signals, you can measure oral signal, you can measure the flow, and you can measure. So computer can read these things. With the current signal processing method, you can get more stuff. So in our study, you can calculate the PTP from there, and based on some landmarks. So this is one of the way we measure the PTP, and we hope it's more subjective, more objectively. So this is one of the measurements to do the landmarks. They all published, and we found the reliability is more accurate for these on the mechanical interruption. We also feel the PTP is also more active. The subaqueous pressure is also more accurate based on this data. And more important, we did at a different age. And we feel, we found it in the younger children. So it's less than like 8 years old. It's hard to do the papa methods instead of, but we give the interruption, just have them to do we can measure people like 3-4 years old. So this is something we feel we can extend the reliable method to our children. So we'll still continue work on this. And another line of project I like to talking about is how to choose the surgical intervention. I think this is very important, and we should have theory behind it. Not just that I like the cold instruments, I like the laser. We need some data for that. So we did something, and first is we found the vascular lesion for that, and then I know the PDL and KTP laser method is being used. So I really like this KTP method because it's matched with my study. It's enlargement of the capillary, and you don't have to care about cilia, you just go deep and try to destroy these vasculars. And this is the method to change vascular lesion. So this is one of the things I try to, one of my students did for a demonstration. So I think this is a perfect method for the KTP and PDL, even blue laser, not today. So this is one way to do. And it's important without change the other part of the interstitial tissue, without changing epithelium. I'm hoping, of course, you're going to say you always have some energy in some other area, but that's ideal situation. So only target on the blood vessel. And for the healing, it's kind of important. Without changing your fibers there, and then your healing would be grow along the old fibers. If you use a knife to cut it, you never recover the framework. So that is what I would suggest based on my basic science study. The second type of study is we try to keep the surgical intervention not very deep, just surface. For this kind of lesion, of course, it's only on the surface, so we should not use something to go very deep. We should just treat it superficially on the surface. So that is one of the photodynamic method therapy we should choose to do, because we apply a certain kind of way we can keep the lesion in a certain kind of area. And so this is, we need a light for that. And the light don't go to very deep. That's also another good point here. So we are not the first group who did this, and I had a lot of discussion when we started this project with Dr. Wu, and he gave a lot of advice for that. So this is one of the study we did, fundamental study. We tried to see how deep the lesion can go, and we found there is if you put superficially, 5 minutes, you will get good enough of the concentration in the tissue. And also, in the skin tissue, you cannot get in there, but for the larynx tissue, it's more easy to get drug in there. So, and that is one of the study we did for the 5 minutes, see how deep they can go. And also we compare with the systematic injection, and we feel 30 minutes you get exactly the same level of the drug concentration. So 30 minutes is in your office is acceptable. So, and then this is another study they did for the photodynamic study, it's a clinical study, and we used the laser. It's not a KTP laser. It's not a very high energy laser. It's just more kind of lighting. As long as they can trigger the photodynamic reaction, that'd be good enough. So this is different from previous study. So this is small things we developed. And then, so this is the result, and this is of course published. And this is like 1 week and 1 month, they clear the surface area. So this is great. And this is kill the cells, kill the bad cells, especially these sick cells there. And this is another case. Again, this is published. Another study we're thinking about cryotherapy, study, and this is we developed some kind of probes, and we think there could have some advantage with that. Correct me if I'm wrong. So because this method only kill the cells, only rebuild the lymph system, only rebuild this capillary damage, and not damage the collagen framework. So this is we build these things, and we did it on this animal study. It works perfect. So we see it's had a better healing here. Well, these are data. Time is short. We're gonna move to another thing I did. Last things I want to talk about is we try to do a straw formation to see we can make the straw better, because so the straw formation is really people encourage that. And one of the key things, as Ingo described, is it's a back pressure reflects at the lips of vocal foot. So it's basically the back pressure is one of the reasons cause that. And then we try to do some larynx work, and our exercise larynx setup had automatically supraglottic adaptation and subglottic adaptation. So it's so easy, just 15 minutes work. So we found it's important that we put backup pressure there. And then we made a device, which is also published, and then we can control this backup pressure. So nicely, instead of just use a stroke. So this is one of the things we recently published. So these are data. And another study is we did an inhalation study, and we know this is a pretty typical method. How we implement this? So I want to make something useful and just not fundamental study. And then we made a model. We want to know where these liquids are deposited. We can make a model. We also made a computer model. So we can simulate where this aerosol, these droplets, goes. And certainly, if they go to vocal cord, perfect. They go to deeper, probably for lung disease, right? So this is a study, we studied where that goes. And our conclusion is, we need a little bit larger droplets and large aerosol to let the liquids go to larynx level. You know, not anything inhalation would go to that laryngeal level. And the good size is 5 to 9 micrometer. And also flow is important, 15-30 liters per minute, that's good flow. More important is, if you want to go to the droplets go to your larynx, you should have a little bit change adduction, a little bit, like this. Not hard brace. It go to your lung. So, well, we have some data for that. It's not a big deal, but I think it's important. And the voice improvement. The one thing I was just thinking about in my mind, and I like to discuss this with you, in the future, is the voice can improve the public health. That's extremely important. We always do exercise, but how often we sing, that's going to have the same effects like jogging, like running. So these are important. So I did a study, the literature searching studies, published in Journal Voice, and so these we found the singing voice, and then the singing will change many things. So that's one thing, and also do your. And I think another thing that I want to say is, do yourself is important. Do it yourself important. I went to Walmart. I saw all these devices, otoscope, the test your blood sugar and all the hearing aids. And at some point, I was dreaming about this. We could have this scope. We can. It's easy to do. So that is pretty easy to do. And how often we see a mirror in ourselves. We do that all the time. And then how often we see our vocal cord. Are they not important? Especially a singer. Extremely important. We should see more. And the one thing is the voice is like your second face. But how we took care of our second face. So, and actually the voice is the most easy things you can change. So, the face is a lot of surgery. You can't still Jack is still Jack. But its voice you could have a huge change. So I really want pay more attention to that. And give me a few minutes to it. So thank you. I should put this first. And first I like to thank my mentor Ingo Titze to teach me how to do the thinking, scientific thinking, my PhD advisor. And Ingo is always so smart, and he just, always get the right point. I just, I'm still a big fan of Ingo. So, and as everybody else. So, and I really, really appreciate it. You know, when I have a question, I always still ask and consult him. So, and Dr. David Hanson is my first person to give me a job. He was at UCA, and then later doing the chair for Northwestern. And I worked with him for 10 years, and unfortunately he passed away. And so he taught me how to write grant proposal. He taught me more about how to get an ENT project. That's why it makes me more thinking about how to make it useful, and it makes things more useful. And the last picture was Dave Hanson with Dr. Wang. And Dr. Wang is the person directed me the first accumulation project in Shanghai. And he also, with Dr. Dave Hanson, was helped me set up one of the lab in China to do the scope. And that was 1996. And see, I'm an only child, so my parents are very important to me. I immigrated to this country. I would sometimes complain with Dr. Hanson. He said, hey, you can set a lab there, and then we can do the collaboration. So with Dr. Wang's help, I did this. It's a huge impact to me. For 30 years, I could always take care of my father, which is not like my aunts was also left the country. I went to Taiwan for 30 years, never see my grandparents. So, and I'm a lucky person. So, and again, Voice Foundation, Dr. Sav always, when I'm very young researcher, he put me on the advisory board and helped me a lot for these study. And most of my publications go to laryngoscope. It's huge. And also, not just him, but everybody in the Voice Foundation. And I didn't. I was too nervous to go to Gara last night for this talk. But all these people, you guys are the best people. And all this work is done by my lab, the students, fellows, and they did the most of the work. I believe I kind of get the directions to the lab, and they are really the best, and they did all this work. I do want to say something about my family, and then I was raised by my grandparents, and they my grandpa, and that was a long time ago, and my grandma, and they raised me. They're not in the medical area, but they are really, really, valued medical research, and I always thinking about someday I want to be a researcher. And also the other picture, the last picture was my father. Is last year. She was sick with my family, my daughter, my son-in-law, my wife, and they have 2 kids. They're everything to me. And then that was last year. I'm very lucky to spend the last few months after the pandemic there. And the one other thing I should mention is that my father's last thing heard from me before he passed away, 2 hours, 3 hours passed away, and I get this Paul lecture. And I did not make the story. It's Dr. Saloff gave me a call, and I was so excited. I went downstairs. I told him I had this, and then that's the last thing he basically heard. But anyway, and certainly I really like to thank NIDCD. All my work is supported by NIDCD. I probably should put this as the first to supporting. And many schools trained me, so Iowa and the Shanghai ENT hospital. I had lots of friends there. And Northwestern with Dave Hanson, they really taught me so much. And my current institute and University of Wisconsin, Madison.
much.